Morning, this is Babak, Larian, doing another parathyroid question and answer session. It's really, I don't know what to say. This platform has ended up being so much more valuable than I could have ever imagined, especially considering the times that we're in and how little access people have to their physicians, especially when it comes to this very strange and mysterious disease. I feel almost honored that I can provide this. Even it's I don't know what to say about it. It just really is much more amazing than I thought it would be. My relationship with Facebook was very minimal to begin with before coming onto the Facebook Live platform, and now I see the value, at least as it comes to this particular thing in this particular time. I'm amazed of how I can help so many people in such a way. You know, my office is not open, hasn't been open in 2 months, and I haven't been able to see patients, to help patients. Only a few cancer patients that have come that had needed emergency treatment, and you know, the rest are few phone calls here and there, Zoom, whatever. But now with this, I've been able to do this every other week and reach so many people and help so many people. It's just I can't say enough about it, right? So let me go ahead and start by turning on the questions here. Oh, wrong button here. All right, here we go. First question from Ian McTavish. Ian is an a recurring person who's been on before. Hi Ian, good to hear from you. I just wanted to let you know about my surgery. Oh great, which finally took place on Wednesday here in Australia. Very nice. Very nice, Ian. You really helped keep me sane with replies to my questions, and you really informative slides. I think I found the Australian equivalent surgically to you. Great. Please share the name, okay, so that other people know, and let me know. Maybe I'll connect with them. You know, maybe create a network between all of us. We can all help. Once again, thank you so very much. You're very welcome. The below is a quick summary 3 hours after leaving recovery. All finally done. Turns out it's most probably hyperplasia. 3 glands removed, 4th which looked most normal, left but biopsy taken. Glands were only slightly enlarged, which is typical. You know, especially in the patients who have more lower calcium and lower PTH numbers. The tendency for hyperplasia is more. I don't know if we understand why that is yet, but it just happens that people who don't have secondary hyperparathyroidism, don't have kidney disease causing hyperparathyroidism, and have hyperplasia tend to have more subtle numbers. You know, it doesn't mean the impact of the disease is less. It just means that they've been exposed longer, so they don't need higher numbers to really impact their body. In any case, moving on. PTH was low side of normal, but did come down a bit. Don't know figures yet, getting done every 4 hours. Surgeon is being very careful, keeping me probably 2 days. Just seen doctor, everything went well and numbers dropped immediately. Fantastic. PTH went down from 27 to 7. Wow. Needed to drop 50%. Calcium down from 2.7-ish to 2.48. Really good staying till tomorrow. Just to, oh, you're still in the hospital and sending us messages. I love it. Just to be safe. Looks like my body is resetting. I feel strangely normal-headed too. I love it, Ian. And I get to see you. Ian sent a picture along with his message. Nice to see you, my friend. Wow, in the hospital. Picture of himself in the hospital as we speak, with his incision and still some of the yellow cleaning solution, sterile surgical solution on. Very nice, Ian. I feel strangely normal-headed too, just mild headache from not eating. Leg stinging has subsided for a good while, coming back slightly now, mainly left leg. Foot calf muscles still need to pee. Yep. Front of throat is sore around operation site, swallowing is mainly sore there too. So this is a picture of someone who's has had surgery for hyperplasia and is 2 days out of surgery. Very nice to see you, Ian, and I'm so happy for you, my friend. It's gonna bring tears to my eyes that I was able to help you all the way from here. I'm glad you got it taken care of. All right. Heather James, thank you for being there for us, Dr. Larian. My pleasure, Heather. My question is, do you have patients post-surgery that have neck and back issues due to parathyroid tumor wreaking havoc in their body pre-surgery? Well, as you know, hyperparathyroidism causes weakening of muscles, so muscle weakness and so on. The structural integrity of our spine, of our whole skeletal system, is maintained not only by the strength of the bones, but also by the muscles that keep everything in position, right? So when people have rotator cuff injury, which gives them shoulder issues, it's because now the shoulder is not positioned well and is not kept in the socket well. When you do core exercises, right, what you're doing, you're essentially strengthening the muscles that keep your spine aligned and together. And so people who don't do core exercises, right, get back problems, get injuries like that. And so if you have long-term hyperparathyroidism causing weakening the muscles, thinning of the bones, then having issues with neck and back is very common, all right? Heather writes, so that's the reason people have neck and back problems. But the other thing is that we hold tension in the muscles of our neck. So the muscles that attach from the skull to the shoulders are what hold our shoulder up and keep it up, going up and down. Those muscles are where we hold our tension. So when we get stressed out, these muscles tighten up, which is why when we're stressed, we get neck pain, especially on the dominant hand, for me, the right hand, right? That's the side that usually feels more of the pain and discomfort because we tighten up in those places. Now moving up, I'm almost 4 months post-surgery and my back and neck are in a lot of pain, even after seeing my chiropractor regularly. Heather, I would actually advise, besides, chiropractor will make adjustments for you, but it won't strengthen your muscles, right? If you have done any kind of spine scans that show that you don't have disc issues, a bulging disc or anything like that, if that is the case and you don't have those things, then doing core exercises and yoga to strengthen those muscular systems is paramount. I can't tell you how important that is to get your body stronger, get your muscles stronger, so your core will hold your spine together stronger. I started doing yoga about 15 years ago, and prior to that, I was getting back pain in the operating room. And ever since I've done that, I don't get the back pain anymore. If there's weeks that are too busy and I don't end up doing yoga, right? I'll feel the pain, I'll feel discomfort in the operating room. So just not skipping it for a couple of days will give me back pain. So I think that's what you got to do. You just have to make sure you don't have any disc issues that could be exacerbated by doing yoga. And if that's the case, that you don't have that, then you just got to strengthen. 4 months out, if you've had long-standing hyperparathyroidism, which has wreaked havoc in your body, there's a lot of compensation that your body has to go through, a lot of adjustment, and a lot of things you have to do to allow that adjustment to occur in a better way, okay? So hopefully that helps. Jackie, hi Jackie. Jackie's almost a friend at this point. We've talked so often. Okay, Jackie, thank you for your wise, reflective input. As always, my pleasure, Jackie. Do individual adenomas have different set points for calcium, or do we inherit it during fetal development? Very good question. After having one or more, I'll answer that question, I'll show you the graph. After having one more adenoma out of my symptoms, and calcium levels have risen very quickly and are higher than the last time, or is this due to the fact that it's taking over the other rogue glands' role after the excision? I'm wondering if it's just because I've had the disease for so long. So first, let me explain what you're asking. Let me turn this around. All right. So back to the same pictures, right? We are born with a set point. So on the surface of the calcium sensing receptor on the surface of every parathyroid cell is your calcium sensing receptor, right? That receptor is genetically designed with a certain set point. In this picture, the set point is 9.5, right? And when calcium changes from that set point to another number, so if it goes down from 9.5 to 9.4, right? It comes to 9.4 here. Your PTH levels rise up 30%, right? And by rising up, it causes more calcium to come out of the bones or get absorbed from the urine, and calcium goes up, right? Back to 9.5, right? And again, the same kind of thing, if you calcium goes up to 9.6, the PTH drops that much, right? To allow the calcium to go back down to 9.5. So that's a genetic thing. You're designed with this number, your body will keep that number, and for all your life, your body will try to get you to 9.5 if that's the case, right? When you get a parathyroid tumor, what you have is that particular tumor getting a mutation in either the calcium sensing receptor or the mechanisms attached to that receptor, most likely. And so that cell now gets a calcium of 11, while normals are 9, right? So this is the abnormal cell, 11. The normals are 9, right? And as the calcium comes up and the normals stop working, the abnormal, which is trying to get you to this 11 number, keeps working to get you up to that, and the cells duplicate, get bigger and bigger, while the normal cells shrivel up and get smaller and smaller and smaller, right? So that's the basics. So if you have an adenoma, you have it because there was an alteration in the calcium sensing receptors sensitivity for calcium. So now you have a new number. So you went from 9.0 to, let's say, 11, right? That adenoma is happening in one cell, that in one parathyroid, that one cell duplicates, right? It duplicates, gets bigger and bigger, and keeps copying itself and getting bigger until ultimately what you have is a parathyroid, a big, huge parathyroid tumor, right? With a sliver of normal parathyroid at the edge of it, okay? Now, what's happening to the other parathyroid glands at the same time is that if you started, let's see if I actually have that here. I don't actually, but I'll bring it up for you. In any case, if what's happening in the other parathyroid glands is that as this tumor, the adenoma is getting bigger, the other parathyroids start shriveling up. They get smaller and smaller and smaller, right? As this gets bigger and bigger, these are getting smaller and smaller, right? And the tumor continues to grow and grow and grow at different pace for every person, and so on and so forth, right? Now, when you take this out, you have 3 remaining parathyroids, right? And if you get another tumor developing like this 2 years later, 3 years later, 5 years later, 20 years later, the other parathyroid tumor will start growing in one of them and get bigger and bigger and bigger and bigger. And these parathyroids that had, so these parathyroids that had shrunken, after you remove this one, will grow to their normal size, right? And if years later you get another adenoma here that keeps growing, then these guys shrivel up and get smaller again, right? I'll do it in pink, they get small again, right? So if you've done the surgery, and Jackie, I don't remember your numbers. I know you and I discussed it a month ago, but I don't remember the details of your case. But if you had one adenoma removed and calcium levels have risen and are higher than last time, then it means that one of two things. It either means that you have this scenario, that another tumor has grown, and this particular tumor's number setting for calcium is even higher than that. So if the setting for calcium for this one was 11 and this one is 11.5, then the new numbers will be more towards 11.5-ish. Or the other thing it could be is that you are fitting into this category. Let me find it. That you had, fitting in this category, where you had an adenoma in the background of hyperplasia, right? All 4 glands were abnormal, but this one developed the adenoma within it. And once you remove these 3 glands, which were continuing to work and abnormally function, continue to get larger and larger and overproduce, and that's what's causing the numbers to rise up and be higher than what it was before. And I find, at least in my own hand, I find that most of the patients that I've had failures with have ended up having hyperplasia in the background, right? Except that when you develop an adenoma on top of a hyperplasia, that adenoma can be so overactive that it can overwhelm the hyperplastic cells, right? And suppress them. So they may actually be small and look normal. And once you remove that adenoma, those hyperplastic abnormal cells now continue to grow and become problematic. And so that I think is the problem. Therein lies the problem. So, when I have someone come in to see me who've had surgery, they removed an adenoma or 1 or 2 glands and they have failure, my degree of suspicion that there's a hyperplasia in the background is high. And I feel there's lots of reasons for that. And they include the fact that hyperplasia is hard to diagnose. Hyperplasia is hard to figure out in an intraoperative setting. Doctors are appropriately conservative, I feel, when they in the neck, they remove an adenoma, perhaps they see 1 or more or all other 3 remaining parathyroids. It looks normal to their eyes, and if they do radio guidance and put their radio guidance on those parathyroids, there's not a lot of activity. Again, they're suppressed. They may feel, okay, these look visually normal, and the radio guidance is not showing activity. If they do PTH testing, because the adenoma was so overwhelmingly super active and suppressed the hyperplastic cells, there may not be readily producing PTH during the surgery. And so all techniques have a certain degree of failure. I found it in my hands, the radio guidance had more failure, which is why I stopped using it as a routine. I used it in rare cases, but others feel that it works in their hands better than mine, and so they continue to use it. I use my surgical judgment. I use the presentation of the patient. I use the fact that they may have a family history of hyperparathyroidism, which gears me more towards thinking that they have hyperplasia, or PTH findings if the numbers don't drop quite as much as I want them to, right? So the rule is 50%, but if I get someone who goes from a PTH of 100 to 50, exactly 50%, I oftentimes think that in and of itself warrants more investigation. I either will do more PTHs, and if I do further PTHs and it goes from 100 to 50 to 30 to 27, then I'm happy. But if it goes from 100 to 50 to 49 to 51, then I suspect that there's still some action going on, because that doesn't look like a suppressed gland when it comes and plateaus at the exact 50% mark. Anyways, And again, surgical judgment, how the patient is doing in the operating room, what other medical issues they have, all sorts of things plays into it. But I feel that if your surgeon is in the operating room and confronts a situation where they feel like, I'm not sure, it's sometimes better to be conservative than to cause further damage, further problems, and potentially permanent hypoparathyroidism, right? So in any case, I digress. But I think that's one of the scenarios, the two scenarios I was mentioning, Jackie, here. I hope I've said the same thing to you on our phone consult. But if your numbers, again, if your calcium numbers now after having an adenoma removed are higher than what they used to be before doing your surgery, that's cause for alarm, right? It shouldn't be that way. It should be lower calcium, lower PTHs, and normalized vitamin D levels. That's a sign of a successful parathyroid surgery, okay? Kelly, I have a lot of return customers. Hi, Kelly. So I was wondering, Dr. Larian, if there's such a thing as donor glands. Kind of kooky. It's not, and you're not the first person to ask the question, but let me continue. I know, kind of kooky, I know, but I know that glands are taken out of and placed elsewhere in the body. True. So when we do auto-transplantation of a parathyroid, we put it elsewhere in the body. Although not so much anymore. Yes. The reason we don't do auto-transplantation is because it has an 80% success rate. So when you take a parathyroid, you cut it up into little pieces, right? And make a little pocket in a muscle and put it in that pocket and close it. 80% of the time, blood vessels grow into it and it survives, and 20% of the time it doesn't. 20% in my mind is too high a number for a failure like that. So that's why I stopped doing that as much as I possibly can, right? And not always successful in not doing an auto-transplantation. Sometimes I have to, but I try to avoid it as much as I can and use other techniques. In any case, so if somebody ended up with without working glands, would it be possible to have glands donated to try giving parathyroid function to the body? A very good question. So the problem with doing that is your body's defenses. So anything, your immune system is wild. One of the reasons I got into medicine was actually a biology class that I took was actually immunobiology, and the professor was one of these mad geniuses who had a very three-dimensional mind and explained things in a marvelous way. And so I'll try the same. The immune system cells in your body on a daily basis are going all around your body and feeling the surface of cells. Cells, whatever they're doing on the inside, they make a copy of the proteins they're using for that function and put a copy on the surface, right? When the immune cell comes and looks at the combination of these proteins on that surface, it recognizes what that cell is doing. It recognizes that cell has your genetic makeup. So it knows that this cell is yours. So as it's going and feeling it, if the combination of proteins on the cell surface are not appropriate, and it's your body cell, right? And it feels like, uh-oh, this is a precancerous cell, or this cell is going the wrong direction, it actually gets rid of that cell, right? So some days when you wake up and you feel like, oh, I'm coming down with something, maybe I stay home, I'm not working today, and then by the next day you're like, wow, I thought I was gonna catch a cold, but it never manifested. Some days that's happening to you, that's your immune system raging chemical warfare on something that it finds to be foreign or going down the wrong direction, right? Now, when you implant someone else's organ into someone else's body, so if I were to get a kidney transplant, right, and put a new kidney, the proteins on the surface of these new kidney cells are foreign genetic proteins, right? So the immune cells, when they touch the surface of these kidney cells, they're like, wait a minute, this is not our gene. This is not our genetic makeup. These proteins that are on the surface here are not my proteins. Attack. So when you transplant an organ into someone else, you have to suppress their immune system, right? That's why when people get liver transplant, heart transplant, kidney transplants, they go on immunosuppressants. Immunosuppressants are very strong medications, right? So you're intentionally bringing down your immunity. People who have immunosuppression are more more subject to infections, right? They have more like, so during the COVID times nowadays, some of the group of patients that are very susceptible to getting a COVID infection are people who are immunosuppressed. Immunosuppressed because genetically they have diseases that cause immunosuppression, or because they're on immunosuppressive medications, right? Also, immunosuppressed patients are more prone to getting cancer. The same system that defends you against foreign things also defends you against internal things going wrong, right? And so internal problems developing. And so you need heavy duty medications if you were to transplant my parathyroid in someone else's body, right? That person would need heavy duty medications to suppress their immune system. So when you balance the positives and negatives of that against, well, you're hypoparathyroid and it's better to take calcium, high doses of calcium and vitamin D, or get NAT para injections, as you compare to immunosuppressant, those measures are by far better than suppressing your defense systems, right? So that's the best way for me to explain it. And Lisa, as I'm saying this, is just asked, can an auto-transplant parathyroid implanted 2 years ago after original surgery go rogue or over-secrete in a patient who now has hyperplasia? Yes. Yes. I mean, if you auto-transplant a parathyroid that was hyperplastic, so that's what you did. When you were someone, in olden times, when someone, people do it today as well, when they have 4-gland hyperplasia, you take all 4 glands out, you cut the 4th one in half, take that half and chop it into little pieces and transplant it into a muscle. You're taking half of a diseased gland and auto-transplanting in a muscle. In time, that gland is gonna overwork and cause problems. That's why I keep saying, you can't cure patients with hyperplasia, you can control them. You can reduce the number of abnormal cells, right? So that the functionality is not over-functionality, it is appropriate functionality, right? And you're essentially buying time. Your hope is that you've been able to guesstimate it well enough, and that's where the surgeon's experience comes in, so that you can buy the maximum amount of time. Hopefully that'll be a lifetime and they don't have to have a second surgery, right? But it's a guesstimation because let me show you this again. So when a patient presents, and most people have asymmetric hyperplasia, which means each gland is a different size, as you can see here. 4 glands, all 4 glands are hyperplastic. So this patient had all 4 glands removed. This is under the microscope. All of them have abnormal cells, right? This dense population of cells, right? This is abnormal. This is a normal parathyroid right there. Normal looking, where there's fat and cells, but the rest are very abnormal. Lots of dense heaviness, nodularities in it. In any case, so this one is the one that has the slowest growth phase, right? Of all the other ones, this one. So if you're gonna take all 4 and reimplant one back, you're gonna use the one that you can see clearly is growing the slowest because you want the slowest rate. And you cut this one in half, right? You cut this one in half and you take this half and you chop it. Here, let's do it this way. You chop it into little pieces, right? And you insert that in the muscle. In the past, they used to put it in the forearm, right? They used to make an incision in the arm and put it in one of the muscles in the arm because 30 years ago, anesthesia was more problematic than surgery. More people had complications from anesthesia. Anesthetic medications were not so good. They would implant it in the arm so that if they needed to remove it, in the office, they would give a local anesthetic and remove it. But anesthetic is so much better now. And so if I'm going to do an auto-transplantation, I prefer to do it in the muscle of your neck because it's right next to my incision. If I need to go back, I can use the same incision and go easily there. It's pretty superficial. I don't need to go deep, and I mark it so I know which area of the muscle to remove. So that's the gist of it, Kelly. That's why we don't do auto-transplantation. Now, that's why we don't do transplantation from another person. Now, people who have kidney failure get hyperparathyroidism, get a parathyroidectomy, and end up being hypoparathyroid, right? And then they end up getting lots of calcium and vitamin D to compensate, and then they happen to get a kidney transplantation, right? And because of the kidney transplantation, they need immunosuppressions. Those patients, those guys are the perfect candidates to get a parathyroid implant from someone else. So get a parathyroid implant from a family member or a matched person, or the same person who gave them a kidney, potentially, right? And that can work very well. Sally's asking if I can speak louder. Yes. And that can work very well because the person is already on immunosuppressive medications, right? You're not increasing the risk of immunosuppression. You don't have to give more doses of immunosuppression. The dose for the kidney is adequate enough to take care of the parathyroid being transplanted. So in that setting, it can work, all right? So moving on to Mo. Hi, Mo. Could I ask if my one remaining parathyroid gland looks to you to be misbehaving from these serum calcium and PTH readings over the last year? My vitamin D is around 100. Calcium 2.52, PTH 790, range is 1.6 to 6.9 picomoles. Then calcium 2.3, PTH 6.3, calcium 2.4, PTH 4, 2.45, 6.26, 2.38, 3.55. Mo, if you have written these numbers backwards, meaning that the 2.41 calcium and a PTH of 2.55 was the oldest set of numbers, and the newest set is 2.52 and 7.9, it looks like an upward slope in both calcium and PTH. So that's alarming. And then you wrote that ionized calcium is 1.12, which is below the normal, or at the lower range of normal. And PTH is 75, which is on the upper side of normal. Would it help to take small doses of calcium to raise the ionized level and perhaps reduce PTH? Yes, that is actually very good. So let me explain. First, Mo's asking about ionized calcium. Ionized calcium, I gotta warn you a little bit. Ionized calcium, so when you look at calcium in the bloodstream, calcium comes in a couple different forms, right? You can either see calcium that's free floating in their blood, or calcium that's attached to albumin, a protein in the bloodstream. And calcium can attach to other chemicals, citrate and phosphate also, but most are attached to albumin, right? 45% bound to protein, 5% to chemicals, and 50% free floating, generally speaking, right? But if someone has a low albumin state, right, then probably more calciums are free floating, right? So if this person has a calcium of 9.0 and this person has a calcium of 9.0, this person has actually more free floating albumins. Less free floating albumins and more free floating calcium, right? Which means that the active form of calcium, which is the free calcium flowing around, is the one that is reflective of your disease condition. So although both these people have a calcium of 9.0, this person's calcium, true calcium, the free form of calcium, is higher. So that's why the corrected calcium test that some doctors do is they get your calcium and they get your albumin and they do this calculation to figure out the true calcium that's free floating in your blood. Ionized calcium is supposed to give you that same number, this free floating calcium, except that ionized calcium is a very finicky test, right? The machine that checks your ionized calcium is somewhat unreliable in that it needs to get calibrated on a regular basis. So when you go do a ionized calcium test at a hospital, busy hospital that's always doing this stuff, and always their laboratories are recalibrating the system because they're getting 50 ionized calcium tests a day, you get accurate result. If you're doing your ionized calcium in an outside laboratory, not in a hospital setting, where they're doing ionized calcium 1 or 2 a day, they may not be calibrating on a regular basis and with as much accuracy. So ionized calcium, although I order that test, I kind of take it with a grain of salt, and I ask, oftentimes when the numbers don't match up with everything else that's going on, I ask where they did it to see how reliable that is, okay? So putting that caveat aside, if your calciums are on the lower side after you've had surgery, and your PTH is on the upper side, then what you may be suffering from is the hungry bone syndrome, right? So, to simplify, when someone is hyperparathyroid, right, and they have high calciums and high PTH, the high calcium in their bloodstream is not coming from the fact that they're taking too much calcium pills and supplements or eating too much dairy or almonds or green leafy vegetables. It's coming because it's being drawn out of your bones, right? So you guys who have hyperparathyroidism and have high calcium levels, you don't have high calcium levels because you're eating too much calcium. You're having it because it's leaching out of your bone. So actually, hyperparathyroid patients are depleted of total body calcium in their body. When you look at the total amount of calcium in the body, right? And majority of the calcium is in your bones. I think 98% of the calcium in your body is in your bones. It's only 2% free floating in your bloodstream and in the cells of your body doing the work that it does, right? So when they're hypercalcemic and the blood calcium level is higher, that means the bone is leaching off. So the total body calcium is actually lower. So when you correct that and you do parathyroid surgery, afterwards those bones are like, give me my credit back. I want my calcium, I want to strengthen the bone. And they grab the calcium out of the bloodstream because they're no longer fighting an uphill battle against high PTH, right? And so during that kind of environment, the person can end up having low calciums, right? Because the bones are grabbing the calcium out of the bloodstream, and the parathyroids that are not working are fighting against it. They're fighting against it. And when they're fighting against it, what they do is they produce PTH to get the calcium back in the bloodstream, and this battle ensues. So you end up with having lower calciums in your bloodstream, high PTH, which is the fight with the bones, right? And it's an indication that you actually need more calcium in your diet to be able to replenish the bones. So Mo, as I say, you guys are probably more educated about parathyroid than most of the doctors you meet. And so what you're saying is very insightful, Mo, and by taking more calciums, you may be able to overcome it. I would suggest also taking vitamin D fortified calcium, because vitamin D is essential for you absorbing the calcium that you take, and vitamin K2, which also helps your bones strengthen. So that way you can kind of calm every system that's kind of overreacting to the changes in your body, okay? Am I speaking louder? Hopefully it's more clear. Danielle Rossi. Good morning, Dr. Larian. Good morning, Danielle. Why can parathyroidectomy result in permanent hypoparathyroidism? What during the operation causes the occurrence of this unfortunate eventuality? I wouldn't call it an eventuality. It's not, fortunately, it's not something that happens often, you know? And again, I've had 2 patients who've had it, and I still remember them all the time. And you know, I go over my head, how could I have done things differently to have helped these patients more? It is a tough one to live with. It is, you know, yes, it is a known complication of the surgery. It does occur. It's the nature of the disease, but let me explain. Okay, so when you have hyperparathyroidism caused by all 4 glands being abnormal. So let's start with that, right? Then you're going in there and you're reducing the amount of abnormal cells, right? So you're trying to do reduction of abnormal cells to get them to normality, right? To a level where they function appropriately and buy enough time before that one remaining or half a remaining parathyroid overreacts, right? But you are doing this based on a guesstimation. So Those who like autotransplantation and take all 4 glands out and put half a gland back inside a muscle, they have to deal with a 20% hypoparathyroidism that naturally results from autotransplantation. Just the nature of the beast. In fact, I operated on a beautifully magnificent human being whose dad also had parathyroid hyperplasia and had parathyroidectomy and an autotransplantation in the arm. I think they did it at Cleveland Clinic, a very good place, and by a very good surgeon. And that parathyroid never took. And he was just taking huge amounts of calcium and vitamin D, and he was totally fine. He was exercising, he was active, he was okay, fortunately. And so it does happen. I prefer not to do autotransplantation because the 20% is too much for me. I try to, when I find all 4 glands, figure out which one has the slowest growth rate, keep that one in place, and reduce the size. So if I let's go back. If we go back to the scenario of this picture, so obviously if my patient has hyperparathyroidism and hyperplasia, I would remove this one, and this one, and I would keep this one in place, remembering that parathyroids have blood vessels coming into them and blood vessels leaving them. And they always come from the same end of the parathyroid, right? So I would do the surgery very carefully, trying to preserve these blood vessels, and I would go to the pole away from the blood vessels. So now let's say if a normal parathyroid should be, let me do it in black here. Normal parathyroid should be this size, then I would cut this much of the parathyroid, right? Leaving a size that closely resembles a normal size parathyroid, right? If, on the other hand, a normal parathyroid is close to the size, then I would just biopsy and remove only this to confirm that what I saw was a parathyroid, so that if 20 years later this thing grows, right, I know where it is, I biopsied and proved to myself where it was. I don't have to do a guesstimation as to what's left behind. Mo is responding, saying the first reading I gave were the oldest, with the lower calcium level being the most recent. Okay, so inverse of what I thought. So yes, Mo, actually, if your calciums are actually coming down, then yeah, you may be suffering from low calciums in your body, and you may be fighting it. Another way to check for that is doing a 24-hour urine calcium to see if you're putting out a lot of calcium in your urine or not. If you're not, that also is another indication that your calcium intake is not adequate for what your body wants at this point. In any case, Danielle, so in terms of hyperparathyroidism, permanent hyperparathyroidism, in a hyperplasia state, that's what it is. In a non-hyperplasia state, let me go back to this, right? So in a non-hyperplasia state, when you have an adenoma, right? The reason I stay away from a 4-gland exploration on every single patient, right? And I only direct it to those who I feel will need it is because, looking at the statistics, anywhere between 75 to 85% of patients have one adenoma only. Another 10% have 2 adenomas at the same time. 2 or 3. 3 is rare, but it does occur. And about 5% have hyperplasia. These numbers become different when PTH levels are lower. So let me show you. So those numbers are accurate. So 85%, when you look at all patients with hyperparathyroidism, the statistics are 85% single, 10% or 11% double, 5% hyperplasia, cancer exceedingly rare. But when your PTH is less than 100, the number changes to 75% having one and 25% having more. That's why I'm saying the patients who have more subtle disease tend to have more hyperplasia presentation. In any case, going back to this picture. So, no, actually, sorry, a different picture. Going back to this picture. All right. So, when someone has an adenoma, they don't have an adenoma and 4 perfectly normal parathyroids. They have an adenoma and 3 other shrunken parathyroids. So when you go in there and try to find these parathyroids and do a surgical exploration for all, these parathyroids that have blood vessels coming into them, right? The normal parathyroid and the tumor will have a very big, robust one. The smaller parathyroids will have a tiny blood vessel coming into it, tiny blood vessels going out of it, right? And it's true for all of them. And so when you do a 4-gland exploration, and that's my philosophy, when in my mind, if you're doing a 4-gland exploration, right, and you have 3 normal parathyroids, in let's say 75% of people who have a 4-gland exploration are having extra additional surgery that it puts a risk to their remaining 3 parathyroids for no absolute reason, right? Besides the fact that you have uncertainty which gland is abnormal. That's why you're doing it. And 20 years ago, when I was in residency, all my professors were doing a 4-gland exploration, right? Because they didn't know which glands were abnormal, right? Nowadays, because of the scans that are available and so on, you are in majority of cases able to direct yourself to the larger gland and only get that, and then do PTH testing, right? So if this gland is the abnormal one, big one that's working, and it's producing, let's say, 200 units of PTH, and these guys who are very low functionality are putting 5 units of PTH, 7, 11, not a lot, right? After I remove this, right? After this gland is entirely removed, if I check the PTH before removing it, it's 200. And if I check it after I remove it, right? Let's say I check the PTH and before removing it, it's add all of these up, right? So it's 223, right? Total. I'm going to show my weakness in math. So total 223 PTH, right? And after I remove it, right, the PTH at 5 minutes comes down and it's 60, right? At 10 minutes, it's 35, right? And if you track it down and longer, it ends up being 23, which is the amount these are producing. Then the other glands are low functionality and are not overworking. If, on the other hand, I have this scenario here, right? Let's do this scenario in yellow, right? And this gland is putting out 150, this gland is putting out 100, and this one is, for the sake of conversation, we'll use round numbers, 10 and 5, right? So I'll check the PTH of this person, right? Let's say I only saw this gland on the scan and I didn't see the other one. I check the PTH right before I remove this one, and the PTH is 265, right? I remove this gland and I check the PTH at 5 minutes and it's now 115, right? And then I check it at 20 minutes, it's about 112, right? Yes, it's more than a 50% reduction from this one, but it is maintaining in a higher number, okay, and it's plateauing at a higher number at around 50% of the other one, I'm not happy with that, right? That gives me pause. That tells me these numbers are not what I desire, right? So again, 50% of this is 130, right? 132, 133, right? So this is more than a 50% reduction, but it's a reduction that comes down and it's plateauing at a high number, not in the normal range. It tells me that there is more functionality, right? That means that this is the time for me to go look. This is the time that's worth risking potentially damaging the other normal parathyroids in order to find the abnormal one and taking it out. Now, what I try to do when I do scans is try to strategize. I say, I clearly see something here. I see something smaller here that's visible, and I don't see these two, right? These two I didn't see on my ultrasound. I see something here, and I clearly see this one, right? So that way I have a strategy. If I find this, I'll do this one. If in the process of going and finding this one, I didn't see this, I may leave it alone and go to the other side. Take this one out if it's enlarged, right? And check your PTH. So under that scenario, I'm at 112, I take this one out, and now the next number I get is 15, 16, and 12, right? Hallelujah. I've succeeded. I've taken 2 parathyroids out. I avoided damaging these remaining parathyroids by dissecting them, doing anything to them. I don't know where they're at. Great, that's fine, right? And I'll leave you alone. These glands will function normally forever. And if any of these 2 remaining glands in the rest of your life, because you have a genetic predisposition or because you're exposed to a chemical that caused these 2 parathyroids, adenomas, to develop, if this one 20 years later develops an adenoma in it, I haven't caused scarring in this area or this area. I can go in there and remove this with relative ease 20 years later without giving you side effects. And the other thing that happens when you do a 4-gland exploration is, let's say I take this adenoma out, great, I take this adenoma out, I find both of these 2, I biopsy them, right, to confirm that I saw them. In the process of biopsying them, this one's blood vessels get damaged and this one dies. I wouldn't know it because you only need 1 parathyroid gland to function. And this parathyroid gland is functioning. 20 years later, you come to me and you're hyperparathyroid, right? And I do a scan and this one enlarged. Great. Let's do it and go take this one out. I still don't know if this one is alive, right? So I may actually take this one out and make you permanently hypoparathyroid, right? And that's the problem with 4-gland exploration. You create an uncertainty about what you've done to the patient, not because you're guilty of anything, but because your body reacts to you being there. You as a foreign thing being in the body reacts to you. And I try to, when I say minimally invasive surgery, yes, everybody thinks I'm talking about a small incision. I'm trying to be minimally invasive under the surface. And I know the doctors who do 4-gland exploration are gonna have a fit about what I'm saying. And I'm not accusing you of anything. I'm saying in my philosophy, this is how it works. And that's how I choose to practice, right? That's what works in my brain, you know? And when I fail and I have to do my own revision and I know what I've done before and I know where I've got scar and when I haven't, I have an easier time doing that surgery, right? That's where, and when I do surgery on people who've had a 4-gland exploration elsewhere and they come to me, I have a harder time. They're naturally so. They're scarred up more places. I have more information. They've biopsied all 4. I know the location. I know they have 4 glands that were at least present at the time of biopsy. I don't know if they're alive, right? So they give me some information, but they give me more uncertainty. I don't know which glands have remained alive after that procedure, right? So, you know, this goes to show you this is a hard disease to treat. The doctor's experience and their ability to think individually about each patient and say, hey, you get this type of procedure, you get this type of procedure, you get this extent of procedure, you get that extent of procedure, this is the kind of testing I do for you, this is the kind of testing I do for you. Your surgery is gonna take 20 minutes, your surgery takes 4 hours. You know, it's very individual. You do what you can to give the best result with the least amount of complications, knowing that surgery has complications, and unfortunately you try to minimize that. You know, you do your best. The first complication I had after I finished residency 17, 18 years ago, I called my professor. I was pretty much in tears, right? And it was to a beautiful woman, this poor woman. You know, I had such a good relationship with her, and I couldn't sleep. I lost many years of my life over that one complication, right? I was talking to my professor and trying to just talk it out. And he said to me, if you can't handle your complications, you shouldn't be a surgeon, right? And I thought it was incredibly insensitive of him to say that to me, but to some extent that's true. You know, that's surgery is you know, problematic. In any case, that's why I emphasize, when you get your treatment, get it with someone who's interested in this subject, and get it with someone who acts responsibly, who thinks about you as a human being, you know, and tries to treat you as a person, not as a number. All right? That I think is very important. Moving on, off of my soapbox again. Daniel, very good question. Perhaps my answer was too much for you for that, but moving on. Sue Thomas, original parathyroid operation in 2017, pathology report stated hyperplasia. 2 parathyroids were taken. Checked regularly and PTH is slightly raised but calcium normal. Vitamin D is good. Endocrinologist has diagnosed secondary parathyroid disease. Secondary to what? If your calcium is normal and vitamin D is normal, what is it secondary? Excuse me, what is it secondary to? I mean, secondary hyperparathyroidism happens due to low vitamin D intake sometimes. Kidney failure, right? So if you don't have kidney failure, then I don't know if you have secondary. You just, actually, you may actually not have hyperparathyroidism, Sue. If your calcium is in the normal range, your vitamin D is good, and your PTH is slightly in right, I would suggest that you do a 24-hour urine calcium, right? And hopefully you've had a previous 24-hour urine calcium to compare. But if your 24-hour calcium now is low, then what you may have is low calcium intake. And your parathyroid gland may be compensating for that, right? And hopefully that is the case, right? Because that way you can be sure that by taking calcium supplements, calcium and vitamin D, you can actually correct the problem. And if he's saying you're having secondary, right, and it's secondary because your intake of calcium is low, then yeah, that could very well be true. You get the answer with a 24-hour urine calcium, and you can correct yourself completely. Now, if the 24-hour calcium is actually on the high side, right, which means there is a lot of calcium in your system, and your kidney recognizes and tries to get rid of that extra calcium, then what you're dealing with is persistent hyperparathyroidism or recurrent hyperparathyroidism with the 2 remaining glands. Now, that becomes kind of sticky because the risks of your surgery have to do with what surgery you had the first time around. If you had a limited surgery where they only looked at those 2, removed those 2, they came out, they didn't look or find or touch the other 2 glands, then you have 2 remaining glands. You can have a surgery where you focus on taking out. If you do a localization scan and one of them is large and visible, you take that one out and do PTH testing during your surgery to make sure the remaining one, the PTH comes down and stays at a plateau level. Very little risk. You haven't touched the other parathyroid. You've checked in the operating room, your PTH is low, low normal and maintaining, you're good. Now, on the other hand, if you had a 4-gland exploration, right, you see on the scan 1 gland that's enlarged, you take it out, you check your PTHs, and it goes, let's say, from 100 to 30 at 5 minutes to 7 at 10 minutes and 0 at 15 minutes, then you know that's all the parathyroid that was left behind. Then your doctor will do an auto transplantation of the portion of that gland, and you have an 80% chance that that'll work. So those are it. Again, you need an expertise to be able to help you. All right. Make sure if you figure out that this is not secondary due to calcium intake issues, then or magnesium, having low magnesium, check that as well. Then I think it's a good idea to get an expert surgeon to look into this for you. Dawn, original surgery August 2018, hyperplasia, 3 glands removed, 1 whole gland remains. Good, excellent. Calcium never higher than 9.9, PTH elevated to 77, calcium 9.5, 25 hydroxy vitamin D is low at 19. The 125 dihydroxy, the active form of vitamin D, is high at 109. And you can't, of course, you can't take oral supplements. Yeah, because so let me flip this around again. So vitamin D metabolism is extremely important, and let me show you. So vitamin D comes into your body either by ingestion of food, right, or through sun exposure on the skin, which activates cholesterol, a form of cholesterol, into vitamin D3, cholecalciferol it's called, right? Cholecalciferol from either source, cholecalciferol or ergocalciferol, which is D2, they go into the liver, and the liver transforms it into calcidiol, which is the 25-hydroxy version of either D3 or D2. And then in the kidney, PTH activates this enzyme 1-alpha hydroxylase, which turns 25-hydroxy vitamin D3 to 125 dihydroxy vitamin D3, which is the active form. And this is the thing that does the work. This is the one that goes to sorry, too many touches. This is the one, the 125 dihydroxy is the one that goes to your kidneys. Goes to your intestines and tells your intestines absorb more calcium from the food. It tells your kidneys to absorb more calcium from your food. It goes to your muscle, to your bones, and it promotes bone growth, right? So it does a lot of things, right? It's vitamin D3 is very important. Vitamin D is very important because it helps you absorb, it helps your kidneys reabsorb, but it also helps prevent too much loss from your bones. So it plays a very important role in the system, okay? And so when you look at this here, if you have hyperparathyroidism and have high PTH, right, that keeps activating this, you may end up having low 25 hydroxy, but really high dihydroxy, calcitriol, and that will give you symptoms. So one of the signs about that someone has hyperparathyroidism with subtle numbers is that when you give them vitamin D, they get symptomatic and they get ill. Because generally, when people do blood tests for vitamin D, they're only testing this. So the vitamin D panel that you get is only testing this. It's not looking at this end. And this end is an important end, right? Because when this is high, that tells you the amount of PTH coming in for your enzyme in the kidney is too high, and you're actively forming that, okay? So that's probably why, Don. Let's see. So can I take oral supplements because they give me muscle tightness and pain? Endo says shaving down last gland probably not an option, concerned about going hypocalcemic. She's suggesting Sensipar every 3 days to try to lower PTH. I'm in New Jersey. Would like to do a phone call? I'm happy to do a phone call. So, Don, I think you need to have 2 conversations, right? I think you need to talk to your surgeon as well, because your surgeon will know the state of your last remaining parathyroid, knows where it is, knows how large it was. You may want to do a scan and see how large it's gotten, right? To see. Because if that gland has gotten very much enlarged, then your surgeon can go in there and again amputate it again potentially to get it done. But there's still a higher risk of you getting permanent hypo. The idea of doing Sensipar and doing it at a low dose is a very good idea, right? Because it gives you a sense of what can be done, what can be achieved, right? And if you are a physiology that doesn't get complications from Sensipar, then I think you're good. That's a good way to go. A lot of people can take Sensipar and have no issues. Some people develop side effects from it, but it's a worthwhile idea, right? So before consulting me, and I'm happy to talk with you anytime, of course I'm available. Before talking to me, I would have a conversation with your surgeon and may even decide to try the Sensipar for a bit of time to see how it's working for you, because it may do the job, Don. You know, I understand your situation. I know how hard it is, and it's a very difficult surgery to get into the operating room again. But these potential options are good options to exercise and look at. Get more information and make a decision that's worthwhile for you. Okay? Good luck, Don. Holly, sorry I'm rushing through all this. I have another appointment to attend to, but so I'm trying to get through everything. Holly Salomon Bonvisoto, I love that name. I'm sure I massacred it, but I'm going to have my parathyroid tumor removed. Should I request IV vitamin C, are you saying? Or IV glutathione, or both, or something else to support and encourage healing? It all depends. If you are healthy, if you're active, exercising, if you have lots of fruits and vegetables, you don't need anything. You don't need anything external. Your body's repair abilities are by far superior to anything man-made that can be put into your veins or anything else, right? So my advice for someone who's having surgery is to be active, don't smoke, eat well, minimize red meat, right? Minimize processed sugars, right? Have lots of fish and other things. Get protein sources. Protein is important for healing, right? Exercise, get lots of fruits and vegetables. Just make a habit every day, have several servings of fruits and vegetables. You're going to be better able to position your body for healing than IV glutathione or anything like that. Now, if you are ill, that's a different story. You know, that may be a different story, and that you have to talk to about the doctor who manages your illness and how to appropriately prepare you for surgery. All right, so I don't think there's a blanket statement about a particular IV injection that can help everybody. I know vitamin C and zinc help with healing, for everyone. But again, if you're having lots of fruits and vegetables and eating well, you're going to get those things. All right. Arnica and bromelain, I start my patients before surgery and carry them for decreasing the swelling and bruising. But again, those although those are good, they're not the be-all and end-all. It's your body really that does the work. Trifina Eden. What would cause calcium levels to drop within a few months after being high for at least 3 years? Thank you, from Australia. Could having a kidney stone from the kidney affect the levels? Only other thing I changed was that I started taking apple cider vinegar tablets. Well, Trifina, I would warn you against looking at one instead of one number to come up with a conclusion about anything, all right? And let me explain to you why. When you develop a parathyroid adenoma, right? Let me hear it. All right, so back to this chart again, this slide. And the adenoma has, let's say, calcium of 11, right? This is its set point. It wants to get you to this number. The tumor grows, and mostly you're hovering around this number, right? It still follows this graph, right? So it's possible for you to have numbers that are 11, 10.8, 11.3, and then one number, right, that goes all the way in the normal range, a 10, right? And that could be one instant in time, and if you were to check it again, it could be back up here again. So that's the most likely reason to have that. Now, the other things that can affect it is vitamin D. Vitamin D, ironically, suppresses PTH production. So if your PTH is dropped, by taking vitamin D, that drop in PTH could allow the calcium to go back down a little bit. Now, if you take too much PTH, because it helps absorption from the bloodstream, then it can rise up again. So it's kind of a double-edged sword. Is it possible that taking apple cider vinegar affects your absorption of things? Potentially, I don't know, but that could play a role. I don't think the kidney stone is doing anything to affect that. The kidney stone is a consequence of hypercalcemia. It doesn't impact, unfortunately, it doesn't impact the level of calcium in your bloodstream. Because I say unfortunately, because if kidney stones were a reflection of your body getting rid of calciums, right, then maybe you would have lower calciums as you pass them, but it doesn't do that. It's not a filtration mechanism. It's just a collection of calcium, too much calcium sitting in your kidney and coalescing and coming together. Allison Hayes, is there a link between primary hyperparathyroidism and gallstones? Because I have both at the same time and my doctor reckoned not. No, not that we know of. Allison, hyperparathyroidism and gallstones happen in the same patient populations. Middle-aged women are the targets of both disease, right? So they happen to be in that thing. So we do see them in patients who have hyperparathyroidism because it's a disease of middle-aged women, right? We also see lupus more often in that age group, again, because it happens at that time, and so on. And so one doesn't lead to the other. The stones that you have in the gallbladder are not calcium-based, and so this doesn't cause it. And when they've done population studies, the incidence of gallstones is not higher in the parathyroid patients as compared to the non-parathyroid patients. It's pretty similar, so I don't think that plays a role, unfortunately. And even salivary stones that are calcium-based don't happen more often in patients who have hyperparathyroidism. Even though I thought they would, it makes sense, but it just doesn't happen. Those stones have to do with more hydration states rather than calcium in your bloodstream. All right, moving on. Sally JP. Hello, Sally JP. We have been discussing boron this week in our UK group. And Sally, I have to thank you. You guys sent me a copy of the article about boron. Again, this is a mutual relationship, the back and forth. You guys educate me, and I in turn tried whatever I learned, I try to pass on back to you. So I appreciate it. And I read that, and you know, that article that you guys sent me showed that the boron has effects on many organ systems and many things. Sorry, Sally says on my volume is too low. Okay, on many things. My in the operating room, my techs often complain that I mumble, right? That I'm too soft-spoken, which helps in the office setting because patients feel comfortable with me, but it doesn't help in the Facebook Live session. In any case, thank you for the reminder. The boron seems to have an impact in everything in the body, on all sorts of different things. It's an element that's crucial in functionality of proteins, in functionality of systems, just like calcium is important in many things, right? And your question is, and how supplements can reduce calcium excretion in the kidneys to prevent kidney stones? Yes, and they do that. And also to reduce urinary calcium excretion. Do you think for people with normal calcemic PHPT, this might result in increased plasma calcium concentrations to aid diagnosis of primary hyperparathyroidism? Good question, Sally. Let me flip you around and explain. So the normal calcemic patients fall into two categories, right? One category is their normal calcium set point was here. They're on the path of coming to the new calcium, right? So you catch them here, they're normal calcemic, and that's why they say 18 to 40% of normal calcemic hyperparathyroid become hypercalcemic. They're in the process, right? So for this group, if you do things to decrease the urinary calcium excretion, you're gonna speed up the process of seeing higher calcium because this new calcium sensor allows and tolerates higher calciums, right? So yes, it would work. But if you're in this group where your normal calcium is low, 8.5, and you're coming to a high, and the set point of your parathyroid tumor is 9.5, no matter what you do, right, you're not going to get too far up, right? Because you're going to follow this curve. So it wouldn't affect the normal calcemics that are normal calcemic because their set point is in the normal calcium level, but it may affect and show or manifest more in normal calcemics that are in the process of getting to their endpoints, which is hypercalcemic. All right? Hopefully that makes sense. But I think that's probably how it would affect it. Good question. Thank you for the challenge, for the information and the challenge. Marilee Rick. Hello, Dr. Larian. Hello again. Hi, Marilee. I feel like I'm posting every time there's a Q&A nowadays. Thank you again for the work. And my pleasure. Return customers, right? Most businesses love that. I have one concrete question. Is there anything to be done in my case when my PTH values are jumping out of range more and more, but my vitamin D is low? I've consulted with several endos and surgeons overseas, but the answer is the same every time. I need to supplement with vitamin D. Unfortunately, this seems impossible for me. I'm not referring to my discomfort even. As little as 1,000 units leaves me in pain and in complete anxiety for days. So Marilee, I think I explained this just a minute ago. You need to check your 25 hydroxyvitamin D and 125 dihydroxyvitamin D. If your 125 dihydroxyvitamin D is high, which means your PTH is actively converting your 25 to 125, the active form, and the active form is not on a routine blood test, you have to specifically ask for it, right? Then any supplement you take is gonna make the active form go in the toxic levels and make you feel terrible, right? Which would mean your doctors don't know what they're talking about, and you know better, right? So if you do that test and you show that your normal vitamin, the 25 hydroxyvitamin D is low, but your 125 dihydroxy is on the high side of normal or above the normal, anything you take is gonna make you toxic in that, and therefore you shouldn't take it. Your problem is not low vitamin D state. Causing this problem, you have hyperparathyroidism. And that's what you need to show to them, okay? I feel like I'm trapped in a catch. You are. But get the blood test. So I would do calcium, albumin, PTH, 25 hydroxyvitamin D, 125 dihydroxyvitamin D. And if you haven't done a 25 urine calcium, I would do that as well, right? Because if that shows high calcium in your urine, all right, then all of those things point towards a hyperparathyroid state that is not secondary to vitamin D deficiency, but rather a state of hyperparathyroidism, okay? Hopefully that helps. I know you're desperate, but as I said, generally speaking, when patients come in who have a hyperparathyroid picture, have low vitamin D and try to supplement and get symptomatic, that further confirms that they are hyperparathyroid to me. Faye Lewis. Hello again, Faye. Two questions by Faye. All right. I also wanted to ask about magnesium, and then how and why will the parathyroid cells pick those ions opposed to calcium? Is it all happening at the same time in a single cell? It is happening in a single cell, but is the same calcium sensitive receptor uses for all ions? No. Well, I don't know. I don't know if the calcium sensing mechanism is involved with magnesium, but what I do know is that magnesium affects the sensitivity of the calcium sensing receptor. By that I mean, when your magnesium levels are low, your calcium sensor becomes more sensitive to calcium, right? So it almost alters your set point to a higher number. It alters your set point to a lower number. Makes it more sensitive to. So when your magnesium is low, your calcium sensor becomes more sensitive. The setting for calcium becomes lower, and your blood calcium levels end up being lower because your parathyroid mistakenly thinks you want a lower calcium number, right? And so in the setting of surgery, after surgery is done, I always put my patients on magnesium after surgery because I want the calcium setting after surgery to be close to what your body naturally wants so you can adjust back to that number. And I find that to be helpful in preventing you from after surgery going into lows and staying in the low calcium levels. But let me see what more. I understand that PTH cells are sensitive to all ions. Potassium, phosphorus, chloride, magnesium, calcium, zinc. Then what are the mechanisms of magnesium regulation with PTH? I think it's a sensor, such as 125 dihydroxy vitamin D suppresses the release and growth when in appropriate amounts. Well, Faye, I think you and I need to speak, because you're getting way too technical, and I don't know if anybody else is going to benefit from this. I'll just read the question. Such as 125 will suppress release and growth when it's in appropriate amounts. Otherwise, there will be upscaled release to meet calcium demand by bone breakdown and active intestinal uptake and kidney uptake. Magnesium is needed for synthesis and release of PTH, and that, in fact, if one is functionally low magnesium or outright magnesium deficient, then there will be potentially masked a state of primary hyperparathyroidism because the lack of magnesium means that the parathyroid is not producing and releasing PTH as it would. Yes, but so magnesium really affects the sensor, but it also affects the mechanisms of function inside the cell, of course. Faye, I think you and I need to speak, because you're getting into enzymatic conversions and all sorts of things. And then your second message is, I'll read Faye's second message. Doctor, I was hoping you may address this issue. The units for vitamin D tests are very important, as 100 nanomole per liter equals to 40 nanograms per milliliter, and people from different countries use different lab units. Yes, so for all of you that send in your questions, I personally beg of you to send me not only the units, but also the normal reference ranges that your particular lab, your particular country, your particular locale is using. That way I can give you a more meaningful answer. And that way other people, when they're hearing us, know, okay, we're talking about vitamin D in these units, and this is the normal range. And so they can learn, because when I'm rattling off numbers to people and they don't know what the normal is, they may not get as much benefit from the question. And then, all right. Faye, you're putting on a textbook here, my dear. You may want to get on the group and send, like, on the page, put this, what you're asking up, and on the support group, so other people can benefit from the information you're giving about the testing and about all sorts of information you're passing on. This is great information. I think it would be too much for me to just read everything you're saying. I think it's too technical for people to, and I don't think I can dissect it well enough for everyone. But I think it's very valuable information, Faye. So please put it on my Facebook site, put it on the support group so other people can benefit from it. Lala, hello again, Lala. So happy to have you doing this once again. So I did have my consultation with you, and you agreed I was a candidate. Then hell broke out. Yes, hell did. I have an endo here, Savannah, Georgia, and I'm being referred to another because I want a second opinion. My numbers have fluctuated between 10.9 calcium and 10.3. My PTH has always been normal, with the highest, I believe, being 69. D levels between 19 and 28. When I remember, I am taking 1,000 units a day. In the last few months, I feel it is taking a toll on my body. I have no kidney issues or osteoporosis, fortunately, but my doctor keeps reminding me, until my numbers rises or I have real issues, her surgeon will not do surgery. I kind of have an issue when endocrinologists become gatekeepers. I think it would be valuable, Zlana, for you to speak to the surgeon. I think it would be meaningful if you sat down with a surgeon and you discussed it, because the surgeons will have a different perspective, first and foremost. The endocrinologists are deeply affected by some of the view of hyperparathyroidism that they have. Again, you, as a patient who are suffering from this, or seeing endocrinologist after endocrinologist, or the same endocrinologist for a long time, for years and years, until he or she decides you're a candidate for surgery. And let's say you do the surgery and the surgery is successful, you're never gonna need to see that endocrinologist again, because they can't do anything for you. Your surgery's done, it was successful, the abnormal parathyroid is out, you're now having normal parathyroid function, you have absolutely zero reason to go to a doctor to see them. And so they don't get a gestalt feeling. And so I often find that they sometimes become too much of a gatekeeper. Now, Lala responded immediately to me. I spoke to surgeons twice, and she said absolutely no surgery. Then, well, let me read the rest and see what else I can do for you. Okay. And always remind me I'm over 50. Blast your endocrinologist. She says I'm depressed and that's why I feel this way. Laugh out loud. I am now. I've had anxiety most of my life, but suddenly 2 months ago started having panic attacks, and some days of low mood, headaches, which I've never had, also began. I do know this pandemic has not helped. My reflux is horrible. All of us are having reflux, my dear. You're right. This pandemic is giving us all anxiety, of course. Along with chronic constipation, I have back and neck issues, all flaring up. My body seems to be breaking down. I woke up Saturday morning with a breast infection. She believes I'm looking for some miracle and surgery is not it. I'm at such a loss. I'm feeling depressed. I'm seeing a therapist. I just don't feel I'm being heard. I don't feel well. My endocrine highly rated to me. She just says with such low number surgery is too risky. Because I was honest with her, and when we met, that I had anxiety, but always managed to by tools I know, she seems to attribute everything to that. Yes, people tend to box other people into categories and disregard them. You know, even though my scans show something, she just says that is something. California Surgery will be a GoFundMe page. Laugh out loud, any suggestions? Lala, I don't know what to tell you. Part of the reason I've gotten into this field is patients like yourself. You know, again, I keep talking about the Swedish studies that showed that patients who have low numbers, the ones who had surgery compared to the ones who didn't have surgery, when they checked them again a year later, they did quality of life surveys. Those surveys showed the same numbers, right? Which to them it meant that it didn't do anything, right? And I need to make a slide about those. But there are flaws in that system. There's some flaws in the way they did that study, and a lot of endocrinologists use that to say when you have low numbers like this, there's a low chance that anything is going to help you. And I think partly they say it because you know, when patients have these lower numbers, they have a higher chance of having hyperplasia. And so when you have hyperplasia surgery, there's a higher likelihood of having permanent hypoparathyroidism. And so a lot of endocrinologists say they want to shy away from that and stay away. And it's a complicated issue, you know, and I can't blame them so much because that's what they see. I mean, they see what they see and they try to give you the best advice based on what they see. But what I say to that is that those Swedish studies took every patient that came into the hospital and was found to be hypercalcemic or have hyperparathyroidism with low numbers. They had slight elevations in calcium, right? And put them through the two categories of randomize them to surgery or not surgery, which is something you can't really do in the US, all right? And but they didn't put them in categories of symptomatic patients and non-symptomatic patients. And I think if they had done that, they may have had more meaningful information to tell us. Because if, let's say, the symptomatic group compared to who had surgery compared to the symptomatic group that didn't have surgery show improvement, then they should listen to your symptoms. On the other hand, if the ones who had symptoms and had surgery and were followed for 5 years look exactly the same as the ones who had symptoms and didn't have surgery, 5 years down the line, both categories have the same quality of life, and they're asked specific, parathyroid-specific questions of them along the way at 6 months, 1 year, 2 year, 3 year, 4 year, 5 years, and we see that nothing has changed, then your surgeon, your doctor, endocrinologist is right. I have a feeling they're not, but then they're right. There's nothing that's gonna help you. This is an ingrained disease that's not correctable after being present for so many years, you know? And maybe what we need to do is screening at a much earlier stage to prevent it from getting this far along. Again, I don't know the true answer to that, but you may want to see other surgeons. I know. I think. Let me see if I can find. Let me see. Hold on. Augusta. Dave Terrace is in Augusta, Georgia. You may want to look at that. Michelle Cook says, Lala, you deserve the chance to find out if it will help you. You definitely do deserve a chance. You may want to talk to Dave Terrace in Augusta. His practice is thyroid and parathyroid surgery, so if you have a hard time traveling longer distances, that may be an option. And I know he does outpatient surgery, so that may be an option to look into, all right? My dear, hopefully it helps. All right, let me move on to the last two questions. How is primary hyperparathyroidism diagnosed? Mostly by blood test, right? So by looking at your calcium, PTH, vitamin D, there's a lot of other things that are into it. If you need to figure out a little bit more, I don't want to plug, but on my website, parathyroidmd.com, there's a worksheet that you can print out and use that worksheet to get all the information and collect it in one place, so you can figure out if things look abnormal for you. It has a list of symptoms and everything else. It may be a good resource to help you figure it out. Michelle Cook says, it sure helped this middle-aged woman. Laugh out loud. Michelle, you're awesome. All right. What is the purpose of removing one parathyroid and not exploring the other three? Lisa G. Cowie. Lisa, I explained earlier in the video, so hopefully that helps. I went through the numbers and how the procedures, the way I do it is done, and the logic behind the way I do it. And so if you scroll back a little bit on the video, you'll probably see that, okay? Let me see if any other questions came up along the way as we were speaking. Yusef Martin, doctor would love some insight. Hyperparathyroidism started when I was 29. I've been miserable since. One surgery and no results. Doctor keeps telling me it's low vitamin D. Yusef, I'm gonna need a lot more information to be able to help you. So I'm happy to consult with you, or I'm happy to look at more details on one of these Q&A sessions, or any which way you'd like, but I'm gonna need a lot more information. If you had surgery before, I would need your calcium, PTH, vitamin D levels, 24-hour urine calcium before your surgery, what your numbers were after the surgery, your operative report, what pathology was done, what your numbers have been in the past few years and trending since now, and what are they now? So I can kind of come up with a picture of what's going on and figure out if you actually have vitamin D deficiency that's causing a secondary, or you have persistent hyperparathyroidism, right? A lot more information. All right, let's see. Actually, Yusuf says, I had parathyroidectomy in 2014 in Dallas. Have been battling with low vitamin D since. Similar symptoms slowly returning. All labs except vitamin D come back normal range. Calcium only slightly elevated. What is going on with my vitamin D? Why can't I keep it up? Again, you also need to look at your 125 dihydroxy vitamin D, Yusuf, to see if that number is high. Again, I need a lot more information to be able to help you, but you can get to an answer. Let's see. Bank Carlson, Dr. Larian. I had positive localization with a methionine PET scan at the left lower thyroid lobe. This was even consistent with previous STME. Now during surgery, the surgeon found uptake to be a lymph node, not the thyroid nodule, but lymph node. He took sample from the upper part of the thymus and sample from the upper left thyroid lobe. The pathology result was lymph node and fatty tissue, but no parathyroid. No intraoperative PTH measurement was done, and he closed. I don't even know if parathyroid tissue was removed. He even said that no parathyroids were visualized. I'm slightly just above normal calcium value. PTH says average 90. What is your opinion, doctor? This to me does not sound like a normal procedure. I really need your advice. Very strange that no samples from lower left thyroid lobe was taken. Yeah, banked. That does sound strange. Listen, my friend, I actually have to get off because I have an appointment. I'm actually 3 minutes late to it. Contact me through the office. Let me look at your information and try to figure this out for you, okay? That is it, everyone. I'm so sorry I have to rush off. I wish you all well. Please stay safe and healthy. I know these times are uncertain. I'm reading everything about COVID and Corona as I can. We're hopefully opening up the practice in 2 weeks, but the information is so disparate, so much misinformation out there, and so much lack of information, and the government reactions to it are, sometimes bewildering, and I don't know what to say. Just to say, stay safe, stay smart, treat it as serious, take care of yourself and your family as much as you can. You use your brain. Don't follow what people tell you. Use your brain and be cautious. Take good care of yourself. I look forward to talking to you all again. And Ian, I couldn't be happier for you.